Welcome back to the American College of Surgeons Bulletin Brief from the Front Lines, Surgeons' Voices. With me today are four individuals who are going to help us learn a little bit about rural surgery. I'd like to start out with Dr. Ricketts, a rural surgery expert, health sciences researcher. And Dr. Ricketts, can you tell us a little bit about what you've been doing in your career to highlight rural surgery and to try to optimize it?
Well, since 1988, when I began to, or founded and directed a rural health research center, we've been very concerned with the supply of practitioners in rural places in the United States, tracking both the supply of physicians as well as the number and location of hospitals. And one of the important things that we looked at was really the availability and access to surgeons and rural surgery or surgery in rural places. And the reality is that hospitals have been closing, and the number of surgeons that can practice in rural places has decreased simply because there's nowhere for them to do their work. So that's an important thing that we have to think about in parallel with the supply of surgeons in rural places. In general, the supply doesn't look all that much different over the many years, but that's in total. But the population has gone up and down in different places. And one thing you have to remember about rural places is that no two rural places are alike. There are isolated rural places out in the West. There are rural places up in Maine that are quite equally isolated, but then there are places that are relatively close to fast-growing urban centers, and they will change from a rural to fringe to metropolitan for very long. So the context is rural America is changing. The supply aspects are that there have been responses to this, and rural surgery tracks have developed over time. It isn't just the expectation that one would train in New York and Philadelphia and then go out to Iowa and Kansas, that there are now programs that are intended to develop surgeons who are familiar with and willing to practice under the conditions that you face in rural places. So we've been looking at these things for these 30 years, and the one thing that we recognize is that there is change, that rural places are going to have challenges that are not like those in rural places for both the surgeons and for the patients who require surgery. So if I had to say there was a trend, an overall trend, I would just say it was change. But we are looking at a situation now where we're probably seeing a more rapid decline in access to surgeons in rural places. We're going to talk about the AAMC report, but the WWAMI, Washington, Wyoming, Alaska, Montana Institute for Health Workforce Studies has just released a report talking about a very severe shortage of surgeons in rural places.
Well, while you started that conversation, perhaps you could just touch on the two reports, both the AAMC and the WWAMI report.
Okay, the AAMC report is one of a series of, they started doing these in the early 2000s, 20 years ago, and have updated them from time to time. It's interesting that they started them and they were just workforce reports and workforce projections, and now they're titled The Complexities of Workforce Projections, because it is a very complex process. The AAMC includes surgery as a large group that they do the specific projections for. And they, interestingly enough, the projections that they made 10 years ago for need and demand, the supply actually met the demand that they anticipated. So their initial projections of shortages overall in a national sense have spurred responses in the training of medical students and residents and fellows to the point where the system is responding and it's actually meeting some of the projected goals of 20 years ago. Now, the current report indicates that there will be a future fairly large shortage, talking about up to 100,000 physicians nationally, and for general surgeons between 15 and 30,000 for 2034. Interestingly enough, they've increased the anticipated demand. The AAMC methodology is something that we quibble a bit with, as we do, I won't say conflicting or competing projections, but we have different assumptions about the increase in the numbers of people who are being trained and the uptake, and then the overall demand. We have slightly different assumptions, and we come up with, in some work we did for the Physicians Foundation, shortages, but smaller. It's a little bit more diminished scope of shortages in that. So the AAMC is however, read by many people, very influential, and we have to pay careful attention to it. But I would argue with some of their assumptions. Now, the WWAMI group is a research center, health workforce research center that is focuses mostly on rural places, and they have indicated that there would be a decrease in the number of surgeons going into the decrease in the number of general surgeons. That is, the surgeons most likely to practice in a rural place and most needed in rural places, and that they were going to see a decline in the number of general surgeons from 6.4 per 100,000 to 5.2. That's a decrease of 18%. That's going to create a lot of stress for places that need a general surgeon to keep their operating rooms open and functioning appropriately. So for rural places, general surgery isn't the only surgical specialty that is needed, subspecialty that is required, but it is very key to the functioning of rural health systems. And when one part of a rural health system disappears, it's very difficult to maintain the remainder. So that bodes ill for hospitals and for other structures and systems that are functioning in rural places.
Thanks very much. I appreciate all that information. And one thing you did touch on is that you can't expect somebody to train in a major urban metropolitan center and just decide to go out to rural America to practice, and that it requires special training. So I'd like to turn to Dr. Stavridis to talk about training programs and how one gets general surgery residents to understand rural surgery practice, so they might find it appealing, they might be enticed to go into it.
Thanks, Dr. Weckner. I appreciate you inviting me to this morning. I was in rural practice in a small town in a critical access in Idaho for about 12 years before being the faculty here at the University of Utah the last 8 years. So I've been sort of an official and unofficial mentor to the residents who are interested in pursuing general surgery careers, particularly those who are looking at going out into smaller places. And we're one of the training programs around the country that has worked on a rural training track with Dr. Zuckerman and his group in Kalispell. And so we have, our group and especially me personally have preached what Dr. Ricketts and the group from Chapel Hill has been saying for years, that there is definitely a maldistribution. There's a need for general surgeons out in these smaller places, and the demand is very good because surgeons are aging, the population is aging, the demographics are there. Now, this AAMC report that just came out shows that for surgical specialties, the need as we go forward is shifting more towards urban areas. And that goes a little bit against what we've been saying, but I think the reason for it is population growth and shifting. And unfortunately, I think that's going to mean that some of the places that Doctors Coates and Zuckerman are really familiar with are going to find themselves without a surgeon coming up. I think it's very difficult to train a resident today and then convince them that they should go out and be the lone ranger in some little town and little hospital where they're going to be the only surgeon there replacing a retiring surgeon. This is a big challenge as we go forward, I think.
Yeah, it certainly does sound like a challenge. Maybe you can talk about some of the scope of practice in that area. I mean, the general surgeon obviously is trained to do a lot of things, but there must be transfer mechanisms in place, programs perhaps to bring experts on rotational basis. But what are some of the resources to really make that surgeon be able to function comfortably and offer optimal care to the patient? Because it's clearly not realistic to send every patient with a problem to some major hub.
Yeah, you would think so, but it's surprising how many places still are truly isolated to some extent. I think as hospital systems integrate vertically and horizontally, the mechanisms for transfer and referral and expert consultation get easier. And so we are making some improvement in that. Here in Utah and the Intermountain West, I'm involved with a project with our University of Network Development, where we're trying to do that in some of the smaller places in Utah and Eastern Nevada and Southern Idaho to get some of these smaller surgeons a bit more connected and provide some relief. For instance, just call coverage relief. We have a couple of hospitals that our surgeons are going to every few weekends or one weekend a month to help out with coverage, because if you're one surgeon or even two surgeons, it's very difficult to maintain a 24/7 call coverage for a small hospital.
Yeah, that certainly is a challenge. And I guess if you're a resident contemplating the type of practice which you'll accept after you finish training, that may not be terribly appealing to everybody. But on the other hand, I'm sure there are things that are appealing that they learn while they're in the process. And I'd like to maybe shift gears for a moment and ask Dr. Zuckerman, because you're in, as Dr. Ricketts outlined, there's two different kinds of rural areas. There's rural that's near metropolitan, there's rural that's near other rural, and you're the latter. So what makes people say, I'm going to go and help out in an area like that?
Thanks. And again, thanks for having me here this morning. I'm the chairman of surgery at Logan Health, which is a health system based in Kalispell, Montana. I've spent all of my academic career looking at the delivery of surgical services in rural areas. I'm a hepatobiliary surgeon by training, so my practice has generally been relatively subspecialized. We serve as a referral center for the entire state of Montana, and certainly the western half of the state. And we support quite a few critical access hospitals across the state, which are quite isolated. I've been here for 6 years. I moved from the East Coast. I was in Connecticut. And what struck me when I got here is just there's a really big difference between rural Montana and rural New England. So for example, to drive across the state of Montana, if you started in Bridgeport, Connecticut, you would either make it to Charlotte, North Carolina, or Detroit. So the distances are vast. There are places where helicopter transport isn't possible because the distances are too far and you're relying on fixed wing. There's only one interstate that goes through the bottom half of the state. Like I live 2.5 hours from the interstate. And so just everything, if you're in a little critical access hospital in Glasgow, Montana, you are really, really isolated. So we've struggled with how do we get people to practice across the state. Our best bet has been people from here. And so I've been very involved with the WWAMI program, where Montana residents are looked at almost exclusively for medical education training. But if you have a kid who grew up in rural Montana, they're the people who are going to come back here. On occasion, you have people who sort of fall in love with the concept of life here. It doesn't always work out, and often the spouse is the rate limiting factor because there are limited job opportunities in some of these small towns. There's not 8 billion activities for your children. On the other hand, we do have a rural training track here where we send residents, fourth-year residents from the University of Utah across the state, and they spend 6 months rotating through critical access hospitals, and they're able to see the joy in this practice. So you might be on call, half the time, but you're not in the hospital every night, and you're able to fish and hunt and ranch, and if that appeals to you, that's wonderful, but it's really not for everyone. And so, my worry is that we just make more surgeons, but we will continue to have a maldistribution problem across the country. So to me, this is a tough problem. The ramp up time to make a surgeon is really long. And to get people to practice in small rural areas requires a very specific and certain individual. It's important that they go into this with their eyes completely wide open, knowing what they're getting into, just because, as you know, recruitment and retention is arduous and expensive.
Yeah, all excellent points. And relative to the AAMC report, what do you think will happen for specialists versus generalists? I mean, you mentioned HPB for you, for having vascular surgeons, colorectal surgeons, whoever, surgical oncologists, specialist surgeons. How is that going to play out, do you envision?
So I think that for specialists to practice in rural states, it requires a fair bit of organization and network building. So, our practice is a statewide practice. We certainly couldn't have what we do based on the population of the Flathead Valley, which is where I live. So we've spent a long time developing relationships with hospital surgeons, oncologists across the state of Montana. But there's a clear need for specialists. And as I was saying earlier, there's only 3 colorectal surgeons in the entire state, a population now of 1.1 million. There's obviously work for more subspecialty surgeons. And I don't know if other people across the country have been seeing this, but referral out has been difficult. We've been at capacity. The hospitals in Missoula have been on divert, Spokane's been on divert. So a lot of these small rural hospitals are having a really difficult time getting patients to places where that subspecialty care is available, simply because of bed crunches.
Yeah, definitely challenging. And you mentioned retention. I'd like to ask Dr. Coates, in urban practice, it's very common for people to jump around, and you see somebody in one hospital and a year later they're across the street in another hospital, or move between major cities. Tell us a little bit about flux in rural practice.
Well, as with the others, thank you, Dr. Wexner, for including me and highlighting the issue of rural surgery. One issue is that of simple economics and demographics, and I think hospitals work very, very closely with general surgeons, and one issue in flux, just for example, is the issue of CEO turnover in a small hospital. Is highlighted in several other reports as a barrier where a surgeon may, in the old paradigm, wish to settle with his family and build a life, build a home, et cetera, in a small hospital. But leadership within the hospital or change in the hospital's status may result in change. For example, I'm sitting today in a clinic which was built 5 years ago because a hospital system left here in Southeast Kansas. There were 2 hospital closures, and so communities of 10,000 were left without any hospital, and so that resulted actually in 4 surgeons leaving their communities, and for a time there was no surgical coverage. So the barriers that exist, which are highlighted in this report, are that of the non-insured population is usually pretty high in rural areas, and in addition, then the Medicare, Medicaid population usually exceeds 50%, both of which result in a poor economic viability for both private practice, individual practice, but also for hospitals.
Well, you touched on something that is, to those of us who live in metropolitan areas, somewhat unfathomable, and maybe you can explain it a little more. What happens when there are no surgeons, which is kind of what some bits of the report almost intimate?
Yeah, so you mentioned the phrase the optimal care of the surgical patient, and I think that with that focus, there are various ways in which that can be accomplished, and the residency or the location of the surgeon may be part of that. Here in Kansas, for example, we have paradigms whereby one surgical group in central Kansas consists of about 6 surgeons, but they rotate among 20 different hospitals, and the viability of a small hospital is increased greatly by performing outpatient procedures. And so, for example, with a partnership, a lot of those outpatient procedures can be performed in perhaps 1 or 2 days a month. And then the surgeon isn't responsible for the emergency care, but rather the receiving hospital that employs those surgeons is really responsible for that. And I think that's the paradigm probably that's working in rural Kansas.
Very interesting. I mean, it sounds like from what I've heard, the networking may be one answer with improved telecommunications and rotations. And we're running a bit short on time, but I'm just curious if anybody wants to chime in about the impact of COVID, when all of us have spent a lot more time in this type of scenario looking at each other on a screen rather than shaking hands in person. Has that in any way changed the paradigm of rural care? Anybody wants to take a stab at that one?
Wait, you would be interested in this, Dr. Wexner. I think 50%, 60% of a rural surgeon's practice is in endoscopy, colonoscopy, and that's been curtailed greatly. And I've seen just in the last 3 to 4 months a considerable uptick in advanced colon cancers, for example, and that's been brought on by the pandemic.
And one positive from the COVID pandemic has been the spread of interstate licensing and telehealth, which, some technology and bureaucratic hurdles that have been overcome to allow us to be a little bit better integrated. And hopefully that will help us with some of these problems as we go forward.
And I just want to circle back to, you asked a question of what happens when a hospital loses a surgeon or when there is no general surgeon. And that's often a devastating experience for communities. Patients suffer just because they lose access to timely care, and hospitals really suffer because the general surgeon is often the engine that financially keeps those hospitals afloat. So you lose not only surgery, you also lose endoscopy, you lose the ability to keep patients with diverticulitis, GI bleeding, and recruitment can take years, not months.
Wow.
But yeah, I'd like to reemphasize that the average recruitment is for a surgeon in a rural hospital is over 1 year from data collected by some recruitment firms. So it's an extremely, you have to look at interruptions to services and then have to rebuild them. It's a very awkward pressure on rural hospitals, and there might be a supply of people willing to get to out into a rural place, but the process is actually very time-consuming and disruptive to the operations of rural hospitals.
The other interesting thing is that in these little towns of 7, 8, 9,000 people, the hospital is often the biggest employer. And so, if you look at the history of rural hospital closures across the rural America, it's often the straw that broke the camel's back was the loss of surgical and procedural services.
very, very sobering statistic, certainly. A very informative discussion and a unique set of challenges. So I appreciate your time today and certainly appreciate what you're doing, which is difficult from the sounds of it and from the sounds of the AMA AAMC report, perhaps going to be even more challenging in the future. So look forward to chatting with you again and hopefully seeing you folks in person at the ACS at some point in time.
Thank you very much.
Thanks.
Thank you.
Thank you.